When I started my family medicine practice about 4 decades ago, I never wrote prescriptions for 15 separate drugs for an older person. But as the decades passed in practice, I found that I was writing more and more prescriptions, more and more drugs for older people, and began to become a little uncomfortable with it. But you know, I was following the guidelines, and when you looked at the single disease guidelines, I was pretty well hitting them, or close to them most of the time. And then more time went by, and the number of prescriptions was even greater, and it got to the point where I was very uncomfortable. This did not possibly seem like it could be the right thing. You know, writing of prescriptions for 15 drugs for one person who was 85 years old just started to sound crazy. So then I began to think that perhaps there might be drug guidelines for the elderly out there, so I began to look for them, only to discover that they don't exist.
The initiative that we're going to be talking about today is called Polypharmacy.ca, which is a website that describes guidelines that are specific for people who are frail. Can you tell us a little bit about what polypharmacy means?
We struggled with the definition of polypharmacy. Very frequently you see a number of drugs attached to the definition. We didn't really think that was appropriate, Laurie, because if you're taking 3 drugs and one of them is inappropriate, you shouldn't be taking that drug. So finally what we come up with is polypharmacy is the administration of more drugs than is clinically indicated.
So once we came up with the definition of polypharmacy, we really wanted to consider what are the driving forces that lead to the state of polypharmacy. The first thing we recognized as a driving force is that frailty is not recognized, so that people who are frail and vulnerable are treated with many medications because they commonly have multiple medical conditions. And the other thing is that frailty is not recognized because dementia, which is a key component of frailty, is often not diagnosed. And one study showed that as many as 75% of people with dementia are not identified as having a problem with cognition.
So in terms of frailty, you know, when we're born, our bodies and our organ systems are full of redundancy. But as we go through life and as we age, each health issue that comes up forces us to kind of spend that redundancy over time. And as health issues start to accumulate as we age and we have many chronic different health issues, that's frailty. That's what we mean by frailty. And frailty really is vulnerability to poor health outcomes. And that could be things like mortality, but also really importantly, morbidity. So things like long lengths of stay in hospital, adverse outcomes after surgeries or other interventions, delirium, falls, need for admission to long-term care. All of those outcomes are associated with frailty. And, you know, really because of that, we know that it requires a really different way of approaching the patient. And luckily, frailty can be recognized and it can be measured. And when we were thinking about a tool for this website, we wanted to choose a tool that was easy for clinicians to use. And so we chose the clinical frailty scale that Ken Rockwood developed. And that scores people from very fit all the way down to very severely frail or terminally ill based on their function, their mobility, and their cognition. And so these guidelines, it's important to say, really are focused on people who are severely frail or very severely frail. So these are people who need help with basic activities of daily living.
While you can be severely frail based on physical impairments, you can also be severely frail based on cognitive impairments as well.
Absolutely.
Of course, most commonly we see the combination of the two.
If you have severe stage dementia, by definition, you're severely frail.
Following the clinical practice guidelines for single system illness, your patients were ending up on multiple different medications. And I think that really adds to the point that our system is not set up to deal with people who have many different health issues at once or people who are frail. And we need a new way of approaching, you know, that situation and new guidelines for frailty.
Because of the impact of frailty, we began to realize that we really needed an approach that brought frailty into focus. And so Paige and I developed this approach called Palliative and Therapeutic Harmonization, or PATH. And the intention is to do an assessment that helps health professionals identify when people are frail and how frail they are, and then to use that information for decision making. And doing this, it turns out that patients and their families often don't want aggressive interventions that could upset their mobility, cognition, or function. And this is a family-led decision-making process, so it's actually interesting to find that people are offered things and accept them, but in reality they don't want some of the treatments that are being offered. And so same thing with guidelines, that the traditional guidelines that we have may not be applicable for frailty, and so we wanted to streamline that process and say, well, maybe we could develop better guidelines for people who are frail that considered the impact of frailty as a first step.
One of the things that's important for us to discuss today is how we arrived at these guidelines. Pam, I wonder if you might explain the methodology behind the development guidelines specific to the frail elderly.
Yeah, the first point I'd like to make is that we developed these guidelines in a very collaborative approach with academic detailing at Dalhousie Continuing Medical Education with Dr. Mike Allen and Isabel Fleming. And of course, we have the content experts like Laurie, Mallery, and Paige Moorhouse offering the clinical perspective. The process in developing the guidelines for the frail elderly is similar to any other topic that's developed at academic detailing. We identify the clinical questions that need to be answered. For example, will a drug reduce the risk of having a stroke, a non-fatal stroke, in the frail elderly? We follow that with a systematic search of the literature and a critique of the evidence. We don't really take previous conclusions at face value. We ask whether or not those questions, how this conclusion was reached. What's the evidence to support that conclusion? So at that point, we then have to interpret and apply the evidence to practice, and that's where the collaboration comes in with the different specialists. We have learned that the approach to frail elderly guidelines is very different and has to be looked at in a very different lens. For example, in our statin guideline, we had to go back to the very basics of the trials and look for things like how old was the oldest person in the guideline? Were there any other comorbidities in that population that we might be able to extrapolate that evidence better into the frail elderly? We had to look at whether or not the outcomes were important to the frail elderly and just how they were reported. What are the doses of the drugs? Are they what we use in practice, for example? Are there characteristics of the drug that would make them especially adverse in a person with all those comorbidities that the frail elderly have? Another really important thing is assessment of harms, and we look at that very closely because the harms and adverse effects are magnified in the frail elderly.
So one of the things that was really interesting when we did the statin guideline was to sit down and really carefully think about what outcomes are relevant to frail older people. And so, for instance, a mortality outcome, which is typically considered the best outcome because it's really significant, we decided that probably wasn't applicable to frail older people because there's so many competing risks for mortality. That outcome probably could not be generalized to people who were frail. And then we also looked at the outcome of stroke.
One of the other challenges was teasing out the elements of those composite outcomes, to figure out which elements of those were applicable. And when you're talking about stroke, is it any stroke? Is it fatal stroke? Is it non-fatal stroke? And I think what we felt was most important were non-fatal but debilitating strokes within that composite outcome. And sometimes it's really hard to tease out what number of the total those actually represent.
Yeah, it was very difficult, and similar for MIs, whether it's a fatal or non-fatal MI, and actually even how they defined MI.
So that's where we became uncertain whether there was really a benefit because stroke was defined as fatal or non-fatal, but really they didn't report in the studies we looked at whether the strokes were associated with disability. And stroke associated with disability is an outcome that would be meaningful for the frail, but we couldn't tell how often that occurred. And what you're saying, Pam, and what we found was that for the outcome of MI, there were asymptomatic events within the outcome, and that too is not really relevant for frail older people. With diabetes, it's even more interesting in terms of the outcomes because we're used to saying that treating diabetes by lowering blood glucose decreases the outcome of microvascular events. But in fact, what it decreases is the use of photocoagulation, albuminuria, and a weird composite that described neuropathy that's based on EKG measurements and blood pressure measurements, but not the clinical impact of neuropathy, which is pain and discomfort. So what we have here are just some outcomes that could be important if someone's going to live a long life, and those eventually get translated into a clinically meaningful event. But for the frail elderly, they really don't have the time needed to go to develop those clinically meaningful outcomes.
Yes, and I think that's where we have to have the discussions on what's the balance of benefit and harm, and try to tease out the data enough that we can make educated guesses, because there is no evidence specific in this population. So we do have to have the long discussions, and that's what appears in the guidelines as they are written.
Although many of these benefits take years to realize in the randomized controlled trials that we're looking at, the harms, particularly in the frail elderly, are immediate. So thinking about treatment of hypertension and the increased risk of falls or orthostasis, or thinking about the risks associated with hypoglycemia for treatment of diabetes. So it's interesting to think about focusing on the balance of that quality of life benefit versus trying to mitigate or minimize those very real and immediate harms that can be caused from overprescribing.
So just to give you an example of one of our guidelines, we could talk about the guidelines for treating type 2 diabetes that was developed by the Diabetes Care Program of Nova Scotia in association with our PATH program. And basically what that guideline says is to keep the hemoglobin A1C above 8%. So we're really aiming to prevent episodes of hypoglycemia and to keep the A1C within a range where the symptoms of hyperglycemia are tolerable. And so we define the upper limit as less than 12% as long as there are no symptoms associated with the high blood glucose measurements. In 2012, there was a survey of the long-term care facilities that were offered the guidelines that was performed by the Diabetes Care Program of Nova Scotia. And that showed that of the facilities who implemented the guidelines, 58% of them reported a decrease in blood glucose testing, 50% reported a decrease in calls to physicians or the nurse practitioner, and 50% reported fewer episodes of hypoglycemia, while at the same time 60% reported that episodes of blood glucose above 20 did not increase.
I think that's really important, because I think when we think about those guidelines for diabetes, we often hear concerns about what will the impacts be if blood sugar is too high. So it's good to have some data showing that implementing these guidelines is not causing an untoward increase in the frequency of hyperglycemia in this population.
And of course, when we did the research, we found that high blood sugar was really very common in this age group. For example, the veteran study, which we used to inform our guidelines, on entry, the mean A1C of the population was 9.4%.
One of the things about our guideline that's interesting is that it focuses on stopping, not always initiating. Like, guidelines usually tell people when to start a drug, and so what we wanted to do with our guidelines was to look at when these medications could be stopped and to give some guidance about that. So for instance, our guideline on treating hypertension says if the systolic blood pressure measurement is below 140, and there are no other conditions that you're treating, then medications can be stopped to reach a target between 140 to 160.
I think that it's important to consider that these guidelines are really only part of the solution, particularly in long-term care. Another element of creating change around appropriate medication prescription is the culture within long-term care. And I know that in many long-term care facilities in Nova Scotia, for example, you need to call the decision maker to let them know that you're stopping a drug, but that same phone call doesn't need to be made when starting a drug. And so hopefully having these guidelines will start a conversation in long-term care and start to get the culture moving in a direction where we really focus on making sure that every medication a person is on is right for them at that time in their life. While the focus of these guidelines is making sure that we don't have patients on medications that aren't helpful, I think some of the limitations, particularly of things like the Beers criteria, is that clinicians don't want to have that absolute list of medications that are never clinically appropriate, because it really depends on the context. And particularly in the patient population in long-term care, many of whom are nearing or are at the very end of life, some medications which traditionally we might say are dangerous in the elderly, like benzodiazepines, for example, can be very effective at relieving symptoms at the very end of life, where the risk is not really a clinically relevant factor. So I just think rather than focusing on, use this, don't use this in every single patient, we really need to contextualize it to the individual. And hopefully these guidelines will help foster that approach.
And so even if people don't follow our guidelines, we have given them a full description of why people are doing what they're doing, which isn't really true of the Beers criteria or the stop-start criteria, because it's uncertain how some of these drugs actually got on the list and others didn't get on the list. So I think our approach is really intellectually satisfying because it sets up knowledge for everyone involved and then to apply that knowledge as they would like to. Many conclusions that have been reached and are accepted are actually not based on evidence when you dig down to try and understand that evidence. And that's what's really so exciting about this process, that we could actually come to maybe a slightly different conclusion. An independent review of the American Heart Association guidelines found that 47% of what they recommended wasn't based on high-level evidence.
That kind of speaks to what our guidelines are, because although the evidence will take us so far, in the end, because there are no trials that are specific to the frail elderly, we do need that clinical interpretation and consensus of leaders in the field in order to make those tough decisions on how we're going to apply that evidence to practice.
Rather than using high-level evidence, which we don't have.
Yes, it would be nice if there were studies in the frail elderly, but we just don't have them. So we have 4 guidelines on the website now. What are the next steps?
Well, we're going to work on further guidelines, is our hope. We may need funding for that. But also in the interim, what we want to do is just give simple guidance about how to stop medication. Things like avoiding aspirin for primary prevention, and simple topics that are more straightforward than the previous topics that we tackled.
Another thing that we can work on in the future is giving clinicians some scripts or structured communication strategies to follow when stopping some of these medications, because it can be difficult after someone's been on an antihypertensive for 20 or 30 years and they were told they needed to take it for the rest of their life. If the clinician suddenly says you don't need this anymore, sometimes it can be helpful maybe to have a sort of script to follow, so that person can be reassured that the reason for discontinuing this medication is really in their best interest.
Mm-hmm. I think that's a really important point too, because there is evidence that stopping some of these medications actually improves the outcomes in the elderly. And we tend to think more often that stopping medication is a negative thing, whereas there can be some very positive effects of stopping
Absolutely,
medications,
yeah.
and actually maybe even enhance the quality of life.
Rolling back the years, take back the tears, back to the good old days when we had no fear. Rolling back the nights, taking back the fights, remember the good old days when love burned bright. Roll back the highs, taken by the lies, remember the good old days when we had the pride.